Hello again. I'm Dr. Karen Broquet. I'm the Associate Dean for Graduate Medical Education here at SIU. And this is the second of some short modules to provide you some education about your education. This one's going to talk about your clinical learning environment. In the last module, we talked a little bit about physician competencies and developmental milestones. So this might look familiar to you. This is kind of the timeline of the significant changes, primarily additions, that have been added to the necessary things for your education. All of those boxes in green are directly or indirectly related to the clinical learning environment. So it's pretty much everything. Work hours, we're going to talk about separately in a different forum. Supervision and patient safety, you either have or will be doing separate modules on those. I want to talk just a little bit about some of the major changes regarding the clinical learning environment, the physical clinical learning environment. In 2013, there were a huge amount of changes to how programs and institutions get accredited for GME. Most of them you don't need to know about. But the one big one was expanding the focus of oversight to not just the medical schools and the faculty that are teaching residents, but to the hospitals where they are physically doing their training. So in some large teaching institutions, the faculty and the programs and the hospitals are one and the same. These are called integrated programs. Some big ones would be like Mayo Clinic or some larger university systems where it's all one and the same. A lot of training systems are what they call non-integrated. That's what SIU is. SIU Medical School is responsible for your education, your faculty supervision, your assessment, all those things, but we don't own our hospitals. And so your inpatient training takes place in hospitals with which we have partnerships and affiliations. And historically, when the ACGME would come to visit us for an evaluation of how we're doing, they would maybe go visit the hospitals just to make sure that we were giving you all good call rooms and you had like places to eat and things like that. But it was really sort of secondary to what the medical school was doing. But in the early 2000s, some really jaw-dropping data came out that looked at the quality of patient care delivered by physicians 5, 10, even 20 years after they finished their residency. And what they found out, they compared it to a whole lot of different parameters. And what they found out that the quality of care that was delivered had nothing to do with what medical school you went to, what kind of USMLE scores you had, what kind of awards you had. It had nothing. The only thing that it related to, though, was the quality metrics of the hospital where you did your training. So that really shifted the ACGME to be looking at the importance of the hospitals where our folks train. And that's what they refer to when they talk about the clinical learning environment. So the way oversight and accreditation is set up now, there's kind of a dual pathway. The ACGME accredits programs and institutions based on the concrete requirements that are in all of those requirements we talked about in the last video. But they also do a parallel set of visits to hospitals where residents train. And these are called clinical learning environment review visits, CLEAR visits. And in the CLEAR visits, there are a series of very specific focus areas. These are sometimes also called pathways. So you can see them up there. It's patient safety, mostly transitions of care and error reporting. There's more to it than that, but that's the big one. And also patient safety investigations, which we'll talk about a little bit in a different slide. Healthcare quality, including not just recognizing, but taking active steps to reduce the amount of disparities in healthcare. Working in teams, supervision, well-being, which includes work hours and fatigue management, and then how hospitals manage professionalism. So those are the big focus areas. Usually what happens is hospitals get visited every couple of years and national data gets collected. And then when a critical mass of hospitals are meeting targets, then those targets sort of make their way into the actual accreditation requirements. Because a lot of these things, when they were these clear pathways and expectations, when they first came out, they were brand new. And in the first few years of this, no hospital was meeting the benchmarks because we just had not been asked to before, or we hadn't been measuring or counting. So those are the focus areas. That's what CLEAR is. The other big change that happened in 2013 with this focus on the clinical learning environment was that the expectations for the contribution of learners changed. And the expectation, Dr. Naska is the president of the ACGME, a wonderful human being. As he was presenting this, he said it really eloquently. Our target now is to demonstrate that having learners involved, residents, actually improves patient care and quality. You know, it doesn't seem like a lot now, but before the bar was lower. It was, let's not be dangerous on July 1st. So how can you guys improve care? And you might in fact be saying to yourself, oh my gosh, I'm just an intern. What am I going to do to improve quality of care? Well, the answer is there's a whole lot that you can do. And some of it's hard, but some of it's really simple. Yeah. So how many times in your career so far has someone talked with you about washing your hands? It is the basics. The basic things are the most important. So our local hospitals are no different than any hospitals in the country. We do periodic audits where people walk around just observing various staff members and note how many times they do or do not clean their hands after touching something, going in and out of a patient room, etc. I am not proud to report to you that typically when we get the results of these audits, our colleagues in nursing have the highest compliance rate. Residents are kind of in the middle. Go residents. Attending physicians, I'm sorry to report, usually rate the lowest, but nobody rates 100%. So lots to strive for there. What else can you do? Talk to each other. I know you've heard this before, especially from a medical legal standpoint. Most medical legal bad outcomes relate all or in part to poor communication. Plus, it's just better when you can talk to people rather than typing or haloing or some such thing. Oh, infection control. Just a heads up, in case there's any confusion on your part, infection control requirements are not guidelines. They are not suggestions. They are requirements, and they are there for a reason. So wherever you're practicing, if your infection control experts reach out to you and make recommendations or say, this is what we need to do for this level of isolation, or these are the kind of precautions that you need to take them. So one of the first things you'll want to do when you start is make sure that you're aware of where the PPE is stored, the protective equipment is stored in any of the clinical places that you practice. So all this was important before COVID, but in a pandemic, it's assumed obviously a greater level of importance. Oh my goodness, we are learning so much about the value and the importance of timeouts, particularly in any sort of procedure, and the direct correlation between getting lazy about timeouts and bad outcomes, again, particularly in the surgical arena. It is going to be tempting as you go on in your training to get a little bit jaded about these, and especially if you're in a surgical program, have your mind wander during a timeout process. Number one, please don't do that. But as a junior learner, you can have a really valuable input and role in sort of reminding gently those around you that we got to focus on the timeout because it is important. Ooh, this is probably the biggest one and a little bit harder than washing our hands or talking to each other. Every single time you have a handoff, you have a transition of care, approach it like your patient's life could depend on it, because sometimes seriously it does. The other thing that learners are amazingly valuable in is helping in patient safety investigations. This is whenever there's a bad outcome, any medical organization will do some level of a patient safety organization. Sometimes it's just a focused meeting of the team involved saying, what happened? What were the contributors to the bad outcome? What could we do differently? If there is a outcome or an error that had a seriously bad outcome or involved multiple teams, they'll do something that's called a root cause analysis, which is a very formal process of looking at all the factors. And very often, root cause analyses will end up in some larger systemic improvements or changes. And on a parallel track, all healthcare organizations have a number of ongoing projects to improve the quality of their rhythms, of their services, particularly looking at this kind of scary gap in healthcare disparities. From time to time, hospitals and programs will reach out to residents to take part in these. Please, 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 if you ever get the call or the offer, do it. It's really an amazing experience, and that's how you're making patient care better. The other thing, and I know you've heard this before, but if there's an error, if there's a new near miss, report it, because that's how hospitals find out where they need to focus on these patient safety investigations. The other thing is, in terms of reporting, residents spend a lot more time on the ground learning about how our rhythms, our protocols, our schedules work on a day-to-day, hour-by-hour basis. And no one is in a better position than residents to submit feedback for how to make things better. Oh, okay, this one's easy. I hope. You want to improve quality care? Talk to your patients, and every single time you do it, sit down. I think doctors don't like to sit down when we're talking to patients because we're afraid we won't be able to get out of the room. Okay, there's actually been honest to goodness research on this, and it does not extend your time with the patient to any, sitting down doesn't extend the time with the patient to any significant degree, but it has a huge positive impact on how the patient hears what you're saying. Introduce yourself, your purpose, and your role on the team. You know, it does not matter if that patient has been in the hospital for 2 weeks. You are, especially if they're seriously ill, you might be one of 30 to 40 different caregivers that they see on a given day or a week. And, you know, we all look alike in the scrubs and the masks and such. So even though if you assume that your patient knows who you are, remind them what team you're with, what your role is on the team, resident, intern, supervisor, et cetera. When you're sharing the plan, this should be a review for you, but have the patient paraphrase the plan back for you. I want to make sure I explain this well. Can you say in your own words what the next steps are? And this wording is very important, not do you have any questions, but what questions do you have? All of these pointers are important. But if you've ever been unwell yourself or had a family member in the hospital, you know that on a day-to-day basis, the really important thing is, do your caregivers respect you? Do they care about you? Are they talking to you in a way that's meaningful? And that's a thing that we can do. Some days it's not easy if we get busy, but it's always attainable. The other thing that you can do is be a good supervisee. You either have or will do a module on what that means and the steps it takes to be a good supervisee. Pay attention to those. They really do pay off. They pay off in your education and in the quality of care for patients. And the very last thing is to be an active learner, which is, of course, why we've asked you to do these last 2 modules. Know what your objectives are for any rotation or experience, set your own learning goals, embrace feedback when it's offered to you and actively seek it, even if it's not offered, and then give feedback to your program, because we can't read learners' minds about what's useful for them and what's not. All right, then. I appreciate your attention to this. I look forward to meeting most of you in person in June. And again, if you need to reach out to me, my information is listed there.